A very warm welcome to tonight's virtual Macular Clinic. My name is Kathy Yelf. I'm the Chief Executive of the Macular Society, and it's great to welcome you all here. We've been running these sessions now since the summer of last year in place of the face-to-face events that we like to run during the year to ensure that you can meet and talk to some of the leading clinicians and researchers around the world who are very kind and generous and give their time to us to help bring the latest news on macular events to you. I'm really grateful to them all. Tonight's speaker is Martin McKibbin, who is a consultant ophthalmologist from Leeds. At any time during the session, you can comment in the chat comment, and after we've heard Martin's talk, we'll be able to ask questions. So you can ask your questions through the chat function throughout the evening. And I'll try to make sure that we get through as many as we possibly can. So tonight's session is about a new initiative to try to improve hospital eye care services. Now, we know from all the calls that we hear from our members and from people who call our advice and information service that there are very considerable variations in the way different eye clinics work. And that might be how long people have to wait for initial treatment, or how long between appointments, what treatment regimen they're on, and often what drug is used in treatment for wet AMD and similar conditions. The question is really, what difference do these variations make on the actual outcomes, the results for patients? Which systems deliver the best results for patients in the real world? So Martin, who's joining us this evening, is going to talk about something called the National AMD Audit. And this aims to shed some light on some of these questions and ultimately, of course, aims to improve treatment and care for patients across the board. Now, this project, the National Ophthalmology Database AMD Audit, is being supported financially by some funding, a small amount of funding from the Macular Society to get it off the ground. But it's being run by the Royal College of Ophthalmologists, of which, of course, Martin is a very distinguished member. Your views are going to be needed, and your input into this work is going to be very important as well. So it's really great that there are so many people on the call this evening. So I'm going to introduce you now to Martin McKibbin. Martin, thank you very much indeed for joining us. I'm going to hand over to you now to tell us more about this very important work. Over to you, Martin.
Thank you, Kathy. I'll just try to get my slides up. Thank you for your kind introduction. I'm Martin McKibbin. I'm a consultant ophthalmologist in Leeds, and I've been there for 20 years. So in relation to wet macular degeneration, I suppose when I started work, there was only thermal laser available, and that was a reasonable treatment, but only for a very small number of people. And then I was around at the time that PDT with Visiodine came in, and that wasn't a great treatment. It was better than nothing, but not that much better than nothing. And then I've also seen the arrival of the first injection therapy, namely Macugen or pegactinib for age-related macular degeneration. And now we're in the situation whereby we have 3 licensed treatments which are available and approved and funded for use to treat macular degeneration. So I've been around for quite a long time. Today I'm joined by a colleague, Sophia Theodoropoulos from Gloucestershire. And the plan is that I'm going to present some slides about the Royal College of Ophthalmologists National AMD Database Wet AMD Audit. So good, I've got that out first of all. And before you switch off, either mentally to go and think about what you'd rather be doing, or physically to go and find something better on the television, I need to say that we're very keen, Sophia and I are very keen to get your views about how we should shape the planned National AMD Audit. And I won't use its full title again, I'll just refer to it as the UK AMD Audit. And I need to tell you that this is all subject to funding. So we had hoped to have funding for a 3-year project confirmed by now, but it's nearly there, but it's not quite there. So we're very grateful to the Macular Society for their help in funding the first 6 months of the audit, just to try to get it going, to secure the funding and to appoint the relevant staff. But we haven't yet got the full funding for the remaining 3 years. So the plan is to have a UK AMD audit. So this will be a clinical audit. And you might not have heard of clinical audit before, but the term has been around within the NHS for about 30 years. And essentially it's a quality improvement activity that's designed to improve patient care and outcomes. And in essence, what it involves is looking at your current practice, ideally from electronic records, so you're not having to do double data entry, and seeing how your practice compares to standards and benchmarks and making any changes where there are any that are needed. And the idea behind it is to reassure patients and hospitals, or it might be GP surgeries and commissioners, so the people who pay for healthcare, to reassure them that a service is doing well, or perhaps to flag up when a service is not doing quite so well. And that's very important, particularly when a treatment is very expensive, and you'll all know how expensive the drugs are to treat wet macular degeneration. And I was interested in a recent report from the national charity Fight for Sight that the annual healthcare costs of treating macular degeneration in the UK are approaching 1 billion. So part of the idea of the audit is to ensure that the very expensive costs deliver the best possible outcomes. So there are already a number of national audits, some of which are centrally funded by NHS bodies and some of which are not centrally funded. So amongst the national audits, there's one for hip fractures to try to look at outcomes from hip fractures and ensure that everybody gets the best possible outcomes. There are also national audits for various types of cancer and for cardiac surgery, for example. In addition, hospitals and GP surgeries, for example, are encouraged to do local audits. And these might be fairly generic, on fairly generic topics such as medical record keeping and whether the notes are signed and dated and accurate, or on consent forms, or they might be audits that look at a particular department or a disease area. So that could be waiting times, perhaps for cancer surgery, or in an eye clinic it might be for squint surgery. And you might wonder, why on earth are we doing clinical audit? Well, my experience has been that most people involved in the care of people with wet macular degeneration spend an awful lot of time trying to deliver care, respond to queries. They work with colleagues from pharmacy and supplies to ensure they have the right amount of drug and that it's kept appropriately and they have the right amount of equipment. And they also spend quite a bit of time working with admin staff and managerial staff to ensure that the service runs smoothly at times of holidays or when somebody's off sick, and also to improve capacity to make sure we have enough capacity to meet demand. So because of this, we all think we're doing really well, but actually we have very little opportunity to monitor how well we're doing. Some sites are lucky enough to get one of these, which is the Macular Society Clinical Service of the Year Award. And I'm delighted to say that Leeds got this, but admittedly it was in 2013. So that's a marker of having a reasonably good service. And in 2013, it was obviously quite good, but it's 8 years old for Leeds. And I don't know if we're still doing as well as we were because we've only won it the once. And I guess this is voted for by people who access the service, and by and large, people have only accessed one service to treat wet macular degeneration. So while it was nice to have, and while I think the staff were very pleased to get some recognition, we still don't know how we're doing relative to other units, and that's something which is lacking. So the Royal College of Ophthalmologists has been involved in a national audit of cataract surgery for almost 10 years. And I'm sorry for the greyed out map of Great Britain and Ireland. I did try to get as many, to have as few figures as possible, and to make sure that as many of them as possible had bold text on a bold black text on a white background. And I realise this isn't the case, but hopefully many of you will be able to see that there are a large number of sites in England, Wales, and Northern Ireland, with Scotland to come. And the most recent report about cataract surgery looked at outcomes for 250,000 cataract operations done by 2,000 different surgeons. So the cataract audit has been going for almost 10 years, and it's spearheaded a number of changes in the way cataract surgery is delivered. So it's probably led to some people to stop operating when they weren't doing much cataract surgery, or like me, when they were getting a bit old in the tooth. It's also led to changes in the way that junior eye doctors are trained to ensure that they're adequately trained before they start doing any operations. And it's also led to a number of changes in the way that cataract surgery is performed. And as a result of the cataract surgery audit, there have been some big improvements in the quality of care. So headline figures of what's different now to 10 years ago is that the number of complications or complicated cataract surgery operations has dropped by about 40%. And so too has the number of operations in which vision actually deteriorated rather than improved after cataract surgery. And that 40% reduction means that there are now about 3,500 cataract surgery operations being done safely without problems compared to 2010. And not having to manage these complicated operations with a poor outcome has probably saved the NHS about £2 million a year. And nowadays you can look up the outcomes of cataract surgery at your local hospital on the National Ophthalmology database. So if you're wondering about having cataract surgery and thinking about where to go and have it done, this might be something you'd like to do. And this slide has got the results from the recent audit published last year for cataract surgery done in Leeds for the year previously. And it's quite busy, so I'll try and focus in on some key outcomes. So it looks at complications of cataract surgery for just over 4,000 operations performed in Leeds. And it says that there was a complicated case in about 1 in 200 operations. And that you might think that's a bit of a concern, but that's lower than would be expected given the complexity and the number of operations performed locally. And similarly, if you looked at the outcome of visual loss, that's again 0.5% or about 1 in 200. So lower than expected. And this sort of data should reassure you that actually coming to Leeds to have your cataract operation is probably a good choice. I'm not saying it's better than other sites in West Yorkshire, but it might reassure you that this is perhaps one of the good sites and somewhere you should think about coming to. So going back to wet macular degeneration, many of you will have experienced the symptoms that people describe to me every day. So a lot of the patients I see talk about the world becoming distorted and that straight lines become bent or wavy. They often describe having a grey or a black patch in the centre of their vision, which stops them from seeing scenes outside, and it interferes with their ability to recognise the faces of family and friends. It interferes with their ability to read and watch television, and it might stop them from driving, and it causes them to lose some of their independence. And although a lot of these symptoms are common to varying degrees in nearly everybody with macular degeneration, they're quite difficult for us to measure accurately. And it's certainly not something that we are already recording as part of routine clinical care. So instead, it's quite likely that through the national audit, at least one of the things we'll look at is vision. So many of you will be familiar with the type of eye chart that I've got here. This is called a Snellen chart, and it's the sort of eye chart you'd almost certainly encounter if you went to an optician, and it's quite common in eye clinics. The idea is that you get a certain score depending on the total number of lines you've read, but you can see there's a different number of letters on each line. So if you've got poor vision, you might only be able to read the letter at the top, and it's quite difficult to know whether it's got a bit better or a bit worse because you either read it or you don't manage to read it. So for macular degeneration, we often use a slightly different chart, as shown here in the middle, and you can see there are a number of differences. First of all, there's the same number of letters on each chart, namely 5 letters. And the difference in size between each chart is reproduced all the way down. And so this is quite good for looking at changes in vision. And on this chart, you don't count the number of lines, you read the total number of letters, so you get a score for the number of letters you've read. And also it's quite good at picking up small change in vision, particularly when the sight's poor. So typically we'd use a chart like this to try to record how good an eye with macular degeneration works. And this is a marker of how good your vision is overall. And obviously, as somebody with macular degeneration, you're interested in knowing, how is your eye doing and what's happening to your vision. But when we're trying to look at outcomes between eye clinics, we don't tend to look at one individual. We tend to look at averaged outcomes for everybody in that clinic. So some will do well, some will keep similar vision, and some will do badly. And we're trying to average it for everybody in that department. And if you go back to thinking about what might have happened to you when you started your journey with macular degeneration, I've got 5 green boxes here, and on the left-hand side, it talks about the time that you might have become aware that there was a problem with your vision. And then you might have gone to your optician or to your GP, and you might have got there quickly or hoped it would go away and then finally realised it wasn't. And then your GP or optician might have sent you off to hospital, where you would have had an initial assessment to confirm that you did have wet macular degeneration, to discuss what would happen if you were treated or not treated, and then perhaps to initiate treatment. And during that journey, often the vision would have deteriorated, sometimes quickly, sometimes slowly. And there are a certain number of things that your local hospital might have done to try to limit the amount of vision that was lost during that time. So quite often they might have publicised the fact that they have a dedicated referral pathway for people with suspected macular degeneration. And they might have moved away from having a fax-based referral or a paper referral to having an electronic referral. And they might have promoted the use of this referral service to opticians. And certainly in my hospital in Leeds, we do try to see people quickly once we get one of these referrals. So once you start off having treatment, many of you remember that the initial idea is to give people monthly injection, typically in a block of 3 injections, almost without, as a matter of course. And during that time that you have this so-called loading phase of treatment, the vision often improves, often a little, but sometimes quite a lot. And then thereafter, the idea is to give eyes as much treatment as is needed, but to try to give the right amount for that individual, and then to maintain that vision without it deteriorating further. And again, the amount of whether you're able to do that will depend, as Kathy says, on how much capacity a clinic has. There's no point in me as a consultant saying, I would like you to come back in 8 weeks, but actually the admin team in our hospital saying that we haven't got capacity for that, and I'm sorry, we can't see you in 12 weeks. That's not what's planned. You know, we would need to do something about that. So that could be influenced by how good we are at booking appointments, how easy it is for you to change an appointment, and whether we've got enough capacity. So going back to the plans for a national AMD audit, the College of Ophthalmologists has already done some work to see if it's feasible to introduce a national audit of AMD treatment outcomes, and I think the answer to that is yes. So 4 years ago, it looked at outcomes from 32 different hospitals, and it involved almost 9,000 eyes which were treated, and they were followed up for at least a year. And the idea was to look at vision primarily and see, was there a difference in the outcomes between one hospital site and another. So some of the key vision outcomes after 12 months. So if you compare what happened to the eyes overall in terms of the difference in the amount of letters they could read at 1 year. So in some of the very best sites, there was an average gain of about 6 letters. And that doesn't sound a lot, but that takes into account the fact that some had a big improvement, some had no improvement, and some had a small improvement. So it varied from a gain of 6 letters to a loss of 7 letters between the best and the worst sites. So that's a 13-letter difference. And actually, that's quite a lot. And equally, if you looked at a different sort of way of measuring vision, namely the number of eyes that kept reasonably stable vision, so that's close to what they started with, it ranged again from 90% in some of the best sites that we looked at to about 75%. So generally good, but still a variation. And then also, if you looked at the number of eyes or the percentage of eyes that had good vision, so that's 70 letters on a chart or close to what you might require for driving, then it ranged from almost 50% in the best sites to under 20% in the worst sites. So I think we became aware that there is evidence that there is quite a big difference in the vision outcomes after treatment across sites in the NHS. And then the feasibility audit also looked at processes and other differences in the baseline features. So I said there was a 13-letter difference in the outcomes between sites, but equally there was about a 9 or 10-letter difference in the starting vision. And we know that your starting vision often determines what the vision you'll end up with. And there was also difference in the care processes. So earlier I talked about the fact that most sites will try to give you 3 injections at monthly intervals at the start of your treatment. And some sites can do that, if not in 8 weeks, and certainly in 10 weeks. But we looked at the ability of sites to give that treatment within 12 weeks. And there was quite a big variation. So we know that probably some of the differences in the vision outcomes is related to difference in starting vision, but it's also in terms of the care that you're given in your local hospital. So I said before that there is a plan for the College of Ophthalmologists to deliver a national audit of AMD treatment outcomes. And I've already mentioned that we've had 6 months of funding to get this up and running from the Macular Society. And so far we've got a project delivery team, and I'm involved in that. And I think Beth Barnes from the College of Ophthalmologists is involved in this call. And we've set up an advisory group of NHS professionals. So Sophia, one of my consultant colleagues, is involved, and Geraldine from the Macular Society is also involved in the advisory group. And the professionals, we've come up with outcomes that we think we need to measure, but the key outcome from today that I want is to get your feedback and your input as to what matters to you as service users or patients with macular degeneration. And we've worked then with the companies that provide electronic records to try to let them know that there's an audit, to work out what do their electronic records not collect that we'd like them to collect, and just to work with them better. And we're also trying to secure funding from both pharmaceutical companies and also from the NHS. And we've worked out the cost of the audit, and we're close to getting funding for the first 3 years, as I suggested before. So the advisory group that's made up of professionals, we've come up with a range of outcomes that we think are important and that we should look at. And bearing in mind, what we really want to try to do is find outcomes that will help us to identify which units are doing well and which units are not doing quite well. And the idea is that we'll all be able to learn from the sites that are doing well. So the things that we'd like to look at in terms of vision are, what was the starting level of vision? So what was the average number of letters that an eye could read before it started treatment? And we think that's going to be a reflection of how good the referral pathway was. And each hospital has a role to play in that. We'd also like to look in the change in vision. So that's the sort of number of letters that on average eyes could read after treatment in that particular site. And we'd also quite like to know what percentage of eyes ended up with good vision at the end of a year. So in terms of the processes that can influence that, we want to know how quickly was treatment started. And the National Institute for Clinical Excellence is currently recommending that treatment should be offered or initiated within 14 days of a referral being received in a hospital or at another provider. We're quite keen to look at how quickly this loading phase of 3 injections was completed, and we'd quite like to look at follow-up delays. And these are the things that we're interested in, but as I said, I'm going to come back to getting you to discuss or to tell us what you think are work we should be looking at. So to give you an idea about how this might work, I've got a slide here that shows how the average number of letters changed in 5 units. These are hospitals in West Yorkshire and Harrogate for eyes treated between 2017 and 2018. And I'm sorry it's coloured, and I'm very much aware that that coloured text on a white background might not be ideal for many of you. But in essence, what it's on the vertical axis, it shows the total number of letters read. And I said quite often there's an improvement in the total number of letters read with treatment to begin with. And thereafter, you're trying to keep it as stable as possible with ongoing treatment. And along the bottom, along the x-axis, it shows the follow-up, and it's just over a year towards the end. So you might look at this and think, well, hang on, the site B, which is in red, actually, they don't do very well. So the average number of letters read, the improvement is less than it is all the other sites. And possibly the dark blue, or site A, is also doing less badly. So if you were paying for treatment, you might think, well, hang on, why are those 2 sites not doing quite as well as the other 3 sites, where there seems to be more of an improvement in vision at the end of 1 year? So you can measure vision in different ways, and this is looking at the change in the average number of letters read. And this chart is looking at the percentage of eyes that had good vision, and I've said before there's a definition of that, and it's close to driving to the vision you'd need to be able to drive according to the DVLA. And if you look at this at the best sites, it's about 40%, but actually a site B, which is the red one, is suddenly doing a bit better, although you might still have a bit of worry about that, but definitely be worried about site A in dark blue, because not only were they doing less well on the previous slide, but they're also doing less well on this slide. So you're beginning to think that there's some signals that suggest outcomes at site A, and I can't remember which one it was, but I'm sure it's not Leeds, are less good than they are at any of the other sites in West Yorkshire. And then you might wonder, why could that be? So one of the things we collected was, what's the average number of injections? And if you look at the dark blue and the red site, there are fewer injections given in the first 12 months than there are at any of the other sites in West Yorkshire and Harrogate. And we know that you typically do better the more injections you have. So it may be that actually these sites just don't have enough capacity, or their decision making is slightly different to other sites, and they may need to be more aggressive. So this is the sort of data which we'd like to collect in order to drive improvements in outcomes. So the plan for the AMD audit is to help us to improve patient care and to get better outcomes and reduce the geographical variation which Kathy says that Macular Society know exists. And we want to be able to show centres for the first time how their results compare to other units, both in the area, which might have the same catchment population, and to all the other units nationally. And we really want to learn from the units that are getting the best outcomes and help to get rid of poor performance. And we know that we probably need to look at several different outcomes to identify sites which might be doing less well or might be considered outliers. What we really want is your help to identify the outcomes that are not just important to professionals, but also which are important to patients. So the professionals in the advisory group, we're very keen to look at the difference in starting vision. I've mentioned that already. A difference in how the vision changes, and also the proportion of eyes that had good vision. And we also want to know how well sites do when compared to each other in their ability to get treatment started, to complete the initial phase of treatment, and also to look at follow-up delays. So these are the things that we're interested in. But it may be, of course, that as people with AMD and as service users, that you've got a very different view. So the NICE guidance document on managing age-related macular degeneration encourages sites to give people written information about their condition, both at the point of diagnosis and at every time that they want it. And I know that we can't do that, and it may be that you think actually that's the best marker of a good site compared to a bad site. It also encourages hospitals to be proactive at recommending that people access low visual aids and to put them in contact with an eye clinic liaison officer and, for example, charities in order to signpost them towards help. And I think we know we're all not very good at that. And it encourages to certify people as being sight impaired even during the early phase of their treatment, so that they can access the benefits from that. And it may be that actually to service users that these things are much more important in terms of vision outcomes. Equally, it might be that actually the biggest thing for you is to have a reliable way of contacting the clinic. And I have patients tell me all the time that they spend hours on the phone ringing up to try to change an appointment, which is a fairly easy, which should be a fairly easy thing to do, let alone how to contact the clinic when there's a problem. And it may be that actually what you'd quite like is to ensure that you have time to ask questions and you have staff that listen to you and treat you as an individual and that are sympathetic to some of the problems that you have. Or it may be that actually what you'd really like is to help us to collect some data that shows how much your ability to do things and how your worry about your eye condition is being changed by having treatment for wet macular degeneration, and to give us some data that will help us to convince people that the costs of treatment are justified. So these are some of the things that might be more important for you, and I'd be interested to get your views as to what you think is important. So just a summary, we've got plans to run a national audit of treatment for wet macular degeneration. And the Macular Society has been very helpful in giving us initial funding for 6 months to get things started. And we're hoping to announce that we've got funding for the first 3 years of this project, which will embed it into NHS practice throughout the 4 countries or the 4 home nations. And what we really want is to get your input to help us choose outcomes and processes that are most important to service users or patients. So I said at the start that I didn't want you to switch off, and I definitely wouldn't take an hour. So I'm about on track now. I've spent half an hour and I was going to say thank you. I'm hoping that there's been a bit of chat on the Zoom call, which Kathy might be able to go through. And if any of you've got any questions you want to ask about the clinical audit, you can ask those either to Sophia, my consultant colleague, or to myself. And Kathy might tell you about plans for a survey that we're going to do after this evening. And really, we want that just to try to finesse the outcomes and the processes that are most important to you. And then we will try to include as many of those as possible in the national audit. Thank you.
Martin, thank you very much indeed. That's really brilliant. So we have got quite a few questions, and we'll go through. I've got some questions that have come in that are more general. They're about AMD in general, and I'll come on to those in a minute. But I do want to get through a few bits about these questions. Now, we could have, if I'd thought about this earlier, set up a poll on this Zoom so that we could have actually asked you some questions. But the other way of indicating how you feel about something is in something called reactions. So has anybody got reactions? You can click on reactions, and there is a thumbs up symbol that you can, I'm going to click it now, and you'll see it come up on my screen, a thumbs up question. So I thought what I might do is just ask a few questions to see whether you give me a thumbs up on it. So Martin had a list of things that are really, could be really important to this, but just picking a couple at random to see where we go with it. How many people would give a thumbs up to the appointment system and getting your appointments promptly and in advance of, for example, leaving the clinic? So a really efficient appointment system. How many people is that a really big issue for, that you think is a really good marker of a good clinic, that they don't keep you hanging on so you have to put your whole life on hold while you wait for your next appointment to come through? So quite a lot of thumbs ups, for that, I think. Yeah. And what about some of this sort of softer quality of service? So having somebody to talk to and having time to ask questions. How many people would give that a big thumbs up as a really important measure of a, oh yes, you don't have to, somebody's very brilliantly, so you don't have to, you could just put your thumb up if you've got your camera on, which of course you're not supposed to have, but anyway. So that's another, so that's actually also quite important. So Martin, in terms of this survey, then what you would like people to feedback through us, through the Macular Society, they can do that via the virtual clinic email address, perhaps, with some of the things that they think are most important to the quality of a good clinic. Is that the kind of thing that you're asking people to do?
Yes. So when I've discussed this with Geraldine, Kathy, she was very quick to tell me that the Macular Society has run surveys before and they've been very effective.
Yeah.
I seem to remember a previous one about macular degeneration had responses from, it was either 500 or 750 people. So I think we were hoping to do a similar one again. And I guess there are two ways we could do it. We could either leave it blank and ask people to suggest something that they think would be most useful to try to distinguish a clinic which was doing well and a clinic which was doing badly. So we could either give you free text to say anything, or we could give you a list of 5 or 10 things which we think are most important, and you could then rate those in order of importance from 1 to 5. And perhaps we could do a bit of both. We could give you a list of ones that we think, or Kathy thinks are important, that Kathy and Geraldine think are important. You could rate those, and then you could have the opportunity to suggest something else that we might not have thought about. So my understanding, Kathy, was that tonight we would try and get a bit of a feeling as to what the people on the Zoom call thought were the most important measures, and then we could follow that up with an email in the next few weeks and ideally get as many replies as possible.
Okay, so you can express your views then, either on the chat, say what is the most important measures that you think on the chat, you can put that on the chat, or if you feel very strongly that you want to say something, then I think we can probably we've got 118 people on the call, so it's going to be a bit of a free-for-all, but let's try it. If anybody wants to say something really strongly, that you've got some strong views about what makes a good clinic, or what has made a bad clinic, if you've got some experience, then you'll have to wave, and we'll try and see who's waving and ask you to unmute yourself and speak in person. So have we got anybody waving at the moment? Can we see anybody waving? Okay, I can't see anybody waving at the moment. So Martin, I'm going to give you a bit of insight then from what I know that people have told me in the past about what makes a good clinic. So this business about appointments and clinics, where some clinics are able to give the person the appointment for the next injection before they leave, which gives people a degree of certainty that they can run their lives, they can commit to looking after the grandchildren in the days when you could, or going away for a holiday or a long weekend. And if they don't have that, they sit on tenterhooks day after day, waiting for the appointment to come through. Is this true? I'm not making this up, am I? This is true that people get worried about that. The other thing is, I think communication, knowing when you're expected to have your next appointment. So we now know that lots of people have different treatments, different drugs, and are on different regimens, and they may be sitting next to somebody in the waiting room who has a completely different regimen, and they don't really know why that is, and that can cause quite a lot of anxiety, I think. Does that ring bells with people? Do I see any sign of things? And clearly being treated nicely, being communicated with, having somewhere decent to sit and wait, and having confidence that you're going to get your injection when you need it. People, I think, are anxious about delays. I think that's true. I'm looking at faces to see whether people recognize that. So are there things coming on consistency? Here's an example. Consistency is everything, as in hospitals, not losing notes frequently. So efficiency, isn't it? I think feeling confident about the process. One thing that interests me, Martin, I've been around quite a long time now, and I've probably sat in dozens, if not scores, of meetings about patient pathways and guidelines for treatments. Guidelines are issued by the Royal College, they're issued by the National Institute for Health and Care Excellence. Individual hospitals have their own routines. Why is it, after all this time, do you think that there is still such disparity in the practice when everybody kind of agrees what needs to be done? Why does it not happen?
I'm not sure why it doesn't happen, but I know from my own experience that the NHS is very slow to implement any change, and certainly in my own hospital, the eye clinic is quite a small bit of a big hospital, and the macular treatment service is a small part of the eye clinic. So actually trying to get enough attention for our injection service within the eye clinic is hard, let alone within the hospital. So actually trying to persuade people that our capacity is falling short of what we need to do, and getting that funded, and even when you've got it funded and paid for, to try to get the staff in post and get them up and running and trained can take quite a long time. So we always seem to be behind. Typically we'll appoint somebody which will sort out a problem for 6 months, and then after another 6 months later it works out that we've got the same problem again and we need to try and go out to appoint somebody else, but that process will take time. So it just seems very slow to get to implement any changes.
It's frustrating, isn't it? A comment here on the chat that appointment letters in large print don't always happen and people miss appointments. That's a pretty basic standard, I'd have thought. Send out appointment letters that your patients can read ought to be kind of base one, you'd think, really, wouldn't it? So clearly somebody else points out that it's more difficult since COVID has happened. But that seems to have worked quite well. It's usually prompt, easy to phone and change appointments. People are very cooperative. Somebody else complimenting their clinic. I think I must be very lucky, as all the clinics I've attended for 7 years have brilliant appointment arrangements. And of course, somebody points out that there are more and more people being picked up with macular degeneration. And of course, that is true. The clinics are overwhelmed, aren't they? The demand is outstripping the supply all the time. It's certainly a problem. I think it's important to allow people to be able to confirm that their eye clinic is doing all or most of the things right. So that's an interesting point, isn't it? So being able to benchmark your clinic against others, actually for some patients, could be quite an important thing to be able to do, to give them confidence in the service that they're receiving. Mm-hmm. Do you think patients will do that?
So I'm quite interested in some of the things you've mentioned, Kathy. I said at the start that ideally with an audit, you want to use data that's been collected for every patient at every episode. So often we nearly always measure the amount of letters that an eye can read on the chart, either on the day of treatment or shortly before treatment. So vision is quite an easy one to measure. And so too would be delays in the appointment. So on our electronic medical record, I can write, for example, I'd like to see this person in 8 weeks, and then if the next time I see them is in 10 weeks, the electronic records can flag up there was a delay, and it can tell us how long that delay was. So that data is already being collected. It would be more difficult, but not impossible, to work out whether there was a nice environment, whether the appointment letters were given out in large print, and whether people got them before they left the clinic, but not impossible. For some of the other national audits, what they've done is they've enlisted service users or patients either to enter this data online, so you could choose your department, and then you could fill out 5 questions. One might be, do you get your appointments before you leave the clinic? Yes or no. Do you get the appointment letters in large print? Are you able to contact people to change it? So we could collect that as part of the national AMD audit. But again, we might need the Macular Society's help to do that, just because that data isn't routinely collected in hospitals. And actually, to get somebody to go around with a clipboard and start to ask everybody would be quite onerous. And I think it would be difficult to get that funded. But I'm not saying it's not possible to do with a little bit of creative thinking.
Yeah. Okay, that's really interesting. Infection, complications from the injections, they're not common, but how I mean, this is obviously a marker of quality as well, isn't it? How often there are eye infections and complications from the procedures. Would you count that? And somebody has asked a question, actually, how common is infection after eye injections?
Okay, so I don't know if Sophia is, I think I saw Sophia's name. Is she here?
She's here.
I'm quite keen that she would help me with some of the questions. I don't want her sitting very smugly at home and watching me suffer and squirm.
Yes, hello from me. I have been trying to answer some of the questions on the chat while Martin has been going through the presentation, and I'm sorry if I have not replied, not all of them. So I thought I answered about the 3 different types of injections, because there were questions about Eylea, Lucentis, and Avastin. And now your question is about the rate of endophthalmitis infection. I agree, it is a significant marker of quality in the clinic. So it's quite rare, and all the audits that have been published around the world in the different clinics and in the UK, they say it's about 1 in 3,000 or 1 in 5,000. I think it's less and less as we accumulate with the years more numbers. So if we're counting that 6 or 7 or 8 years ago, it was reported as 1 in 3,000. Now with all this population, we think it's less, like about 1 in 5,000. And it does not change with the different treatment, whether it is Eylea or Lucentis, if it is a question possibly from a person here in the chat. I can see from the chat that most of the AMD people here want a list in our survey. They would prefer a list of points that they would like to raise. That's what I can see, and then leave some space for their comments. So I thought to say that because I saw that through the chat.
That's really helpful, Sophia. Thank you very much indeed. That's really terrific. So that looks like we've got some ideas about how we could structure the survey, which would be really useful. A sort of related question, Martin, is what's the sort of or Sophia, what's the maximum recommended time between injections? Is a question. Now that's quite difficult to answer, isn't it? Because it depends on the drug and B, the person.
Sophia, should I do that?
Yeah.
Yeah, so I think there isn't a maximum recommended time. So it will definitely vary between one person and another. And for somebody who's got 2 eyes with wet macular degeneration, will often vary between the right eye and the left eye. So I think the right interval, the right interval is just the right amount you need to keep the disease under control. So people talk about wet and, or the signs of the disease being active or inactive. And often we look at a scan, the OCT scan, to try to work out, is it active or inactive? So ideally you want just enough treatment to keep your disease inactive, but not, and we're always treading a line between underdoing and overdoing it. So you want to have just the right amount, which will mean that you're not having too many more injections that are needed, so that makes it safe, but also you're not having too few injections, which mean that your vision might be deteriorating or it's at risk of deteriorating. So I don't think there's an ideal number. Typically we would start off giving it at every 4 weeks. And then if it all settles down and looks inactive, we might extend that, for example, to 8 weeks. If it's still inactive, we'll go out to 12 weeks. And sometimes we stick at 12 weeks, sometimes we'll go out to 16 weeks. But if at any time there's a it seems to deteriorate. So supposing it's fine at 8, but it's not so good at 12, you might settle on 10 weeks. And every so often, I feel you should try to push that interval on again. So the exact right interval is just the right amount that you need in order to keep your disease inactive or at least stable.
It's a sort of Goldilocks calculation, isn't it? Not too hot, not too cold, just right.
Yeah, and there's a bit of trial and error within this, but it's usually quite predictable. So once you settle on a certain interval, that seems to work for most people. I'm not saying forever. And then often if your macular degeneration has been inactive or stable for some time, then quite often people are offered a trial without treatment just to see what happens. So in my unit, we often would, if we're going from treating it regularly to observing it, we might shorten the interval. So we might see you in, for example, 6 to 8 weeks, just to check that we haven't made a mistake and it seems to look okay. And then you might eventually swap from having regular treatment to just having treatment every now and again. Do things differently, Sophia?
No, very similarly, and I can say at the same time some comments on the chat. So I can reply and actually reply to some of the people that have been putting comments. So we do the same. We start from 4 weeks. If things go well, we extend to 6 and 8 and 10 to 12. We go up to 12 weeks. I saw a comment from a patient asking whether 14 weeks that he or she has is right. I know some other Bristol, some other trust, the one was before, as a registrar, was going up to 16 weeks. If the scan is good, is acceptable. So it's always the clinical activity and the scans, as Marty correctly said, drives that. And we do offer also a trial. So after having no activity, no fluid, with 3 very long intervals of 12 weeks, we give a trial of not doing injections. But unfortunately, sometimes, as I can see another comment now from Anthony here, sometimes if you give this trial of 12 weeks and then having no treatment, the disease becomes active again, we need, unfortunately, to go back to 4 weeks. So we cannot predict, and we try to extend as much as possible, and after of a year of having stable disease with no fluid, we try to give a trial of no injections.
Okay, that's lovely. Thank you very much indeed. Beth from the Royal College has pointed out that this is not just in England, that this is all, we need to look at Scotland and as well. So that's a very important part if we've got anybody on the call from Scotland. So we've just got a few minutes left. So I'm just going to rattle through, Martin and Sophia, if I may, just a few general questions. A question very, very quickly. These are one-line answers really in the main, so I can get through all the questions. This comes up quite often. The risks versus the benefits of having a cataract operation when one has wet macular degeneration. Is that something that I think by and large people recommend that the cataract operation can go ahead, Martin? I think that's right, isn't it?
Yes, I think go ahead and perhaps just be extra cautious after the cataract has been removed to make sure that the macular degeneration hasn't become active again. I think that's relevant. And obviously when you take out cataract, when you do a cataract operation in an eye that's got macular degeneration, the outcome is always a little bit unclear. So it often makes some improvement, but the improvement is never going to be huge.
Thank you very much. Somebody points out that people have wet and dry macular degeneration simultaneously very often. And the question is, does the dry continue to progress in spite of the treatment for the wet? And sadly, I'm afraid I think it does in most people. Is that right? Sophia, do you want to answer that one?
Yes, and unfortunately, I think the majority of the patients, and I think that's something that not everyone understands, is that they do have some changes of dry macular degeneration in the way that the injections treat only one component of the disease, which is the new vessels that bleed and they leak. So we treat only the fluid. But at the same time, we get this scarring, this retinal pigment epithelium changes, which is what actually changes first when the disease starts, before it becomes apparent. So unfortunately, these changes do continue, and Macular Society has funded a lot of research projects on how to combine treating the leaking vessel and the fluid, and at the same time reduce the fibrosis, the scarring. And that's why, unfortunately, we don't get further improvements, or get the improvement initially. It never goes back to 6/6 vision because of the scarring that has happened, and there is a very, very slow decline in the vision because of the dry AMD being in the background. Hopefully in the future there will be something to stop also the fibrosis and the scarring that comes at the same time.
Thank you. Yes, so we know there's quite a lot of treatments now coming through the later stage of clinical trials, which means that there is some promise on the horizon. Another question, we get a lot of questions at the Society about nutrition and the use of nutritional supplements. And someone who has now got wet macular degeneration, had been taking supplements, says quite clearly didn't stop them getting the wet form. Should they still, is it still worth taking these supplements, or are they a waste of money now?
So I think the main benefit of multivitamin supplements, so these are things that contain lutein and a variety of other agents, was to stop you developing wet or dry macular degeneration in the first place. So if you've got good vision and you're worried about your eyesight deteriorating, then they offer some benefit, but the benefit is not huge. If you've already got wet macular degeneration in both eyes, then there's probably not a lot of reason to take it. Although occasionally some people tell me that they think their vision is a little bit better when they're on it. But in general, then you probably missed the boat.
Okay, thank you very much indeed. Eye drops, these injections are a burden, aren't they, for everybody, including the NHS as well. Is there any hope for eye drops rather than injections, do you think? Is that a realistic possibility?
I don't know.
Can answer that?
Yes, I can answer, because well, I have been personally involved in a research project that is currently in process, that is with the University of Bristol and the University of Birmingham, and is actually developing drops for wet AMD. But I'm sure there will be some other projects around the country and around the world. My personal opinion is there is hope, but we're a bit far from that. So I cannot see that in a very near future. As far as I know, this project with the University of Birmingham is the only one running in UK, and still it's in a very basic stage. I'm not sure if Martin is aware of anything else, and it is about developing eye drops. So I think there is hope, but probably not for the next 5 years.
One of the difficulties, of course, is that the eye is this beautifully constructed organ, isn't it, that has evolved to protect the back of the eye from foreign material. So it puts up all these defenses, doesn't it, to stop something on the surface of the eye, at the front of the eye, getting to the back of the eye. You've got to overcome the biology of the eye, rather.
Yes, and this is the whole point of all these different projects. So how actually to penetrate, so how actually the medication can go into the eye, because unfortunately there are all these layers of the cornea and the layers and go in the back that you cannot get through and penetrate to get into the retina.
Thank you. Sorry,
Martin. That might come a bit earlier is essentially a reservoir system. So you can have a device that's put into the white of the eye that holds enough drug to last for up to 6 months, and then that can be refilled for another 6 months. So that might be that you could have fewer treatments, and that the drug would come out of this reservoir over a period of time. So that might reduce the amount of treatment that you were going to need, and it might reduce the number of visits to hospital.
Yeah, there's some very interesting technological solutions coming through on the horizon. Just very quickly, a question that I think many people may experience when the vision is different in one eye from the other. So this person can watch subtitles, and the subtitles can be normal size or big in one eye, but very small when they close and use the other eye. So this is to do presumably with the distortion in the different kinds of distortion in the retina from one eye to the other that causes this difference in size of object in front of them. Is that right?
Yes, I think when the retina is lifted up from its normal position, either because of the fluid underneath the retina or because of scarring, then often objects in that eye would appear smaller or further away than they are in the fellow eye. And that's something that we see not just in macular degeneration, but also in other problems affecting the retina. So it may be related to the movement of one retina out of its normal position compared to the other.
And another phenomenon that people experience is sometimes their close vision is distorted, but their distance vision it seems to be much better. Why would that be? What was that phenomenon for? How does that work?
I don't know, and I can see Sophia's looking as clueless as I am. So we know most of the people I see who've got macular degeneration, they do say it affects reading, but reading and close vision tasks much more than distance. So that's quite common. Yes, so that's not really an explanation to your question. I don't know if Sophia's got anything better to add.
I just wondered whether it was to do with when you look further afield, you're using all your peripheral vision as well. So people use their peripheral vision for navigation. I don't know whether that's more. I don't know whether that's got anything to do with it. That if you're focused, the distortion appears to be more significant in the field of vision. I don't know. Could that be a reason? We don't know the answer to this question.
Yeah, no, not sure. No, Kathy, you're only meant to ask questions that we can answer, not try and catch us out by asking questions that nobody can answer.
I'm very sorry. I'm sorry we don't know the answer to that question. And I think I've just got one very final one, which is really about the length of time between a diagnosis of dry macular degeneration and significant loss of vision. What sort of time scale would people expect to have that experience from the period of diagnosis to significant loss of vision?
So you said dry. Did you mean dry or did you mean wet?
Well, the question was dry.
Okay. So there is a change. If you look at the speed at which vision deteriorates in dry macular degeneration compared to wet, on average, then there is a definite difference. So for wet macular degeneration, without treatment, the average is, and I would expect to lose 5 letters on that ETDRS chart in 3 months and 15 letters at a year. But again, that's an average. So some people will be quick, some people will be slow, but on average, that's the rate. And it is slower for dry macular degeneration, but I can't immediately remember how much slower. So I always tell people that the 2 types of macular degeneration are a bit like the tortoise and the hare. So wet macular degeneration is the hare, it gets there quickly, and the tortoise is the dry macular degeneration. It causes the same problems in the end, but typically over a much longer period of time.
Okay, thank you very much indeed. There is a question, which is how many people in the UK have wet AMD? And we know that this is an increasingly big problem because of people living longer, and one of the biggest risk factors for macular degeneration is age. The older you are, the more likely you are to get it. There aren't very good up-to-date population studies, are there, of how many people have this? So we have to take it from historical and looking at a number of studies over time and extrapolating really from those. I think we don't have a clear hard and fast count, do we?
No, I think you're right. There were some population-based studies done in Australia and the Netherlands and in part of America several years ago, and they were looking at a population similar in terms of its genetics or ancestry to the UK. So I think from those we can extrapolate what the number of new cases is. But I think we don't know it accurately, and those studies are quite old now. And furthermore, as you pointed out, the age of the UK population, or the number of people living longer, has increased. So we'd expect the numbers of new cases of wet macular degeneration to be bigger than was predicted 5 or 10 years ago.
So I think when the first treatment, Lucentis, was approved, commonly used treatment, Lucentis was approved about 13 years ago, something like that. It was estimated that there were about 40,000 new cases, 45,000 new cases of wet macular degeneration every year. And a piece of work that we did at about a bit later than that looked at all these old population studies and made some new calculations on it, suggested that there were about, this was in 2010, about 520,000 people with late stage macular degeneration, dry and wet. in the UK, and that would double by 2050. So I think we're probably talking around about 300,000 people altogether in the UK who have wet macular degeneration. That's not a hugely accurate figure, but it's that sort of ballpark. Martin, would you agree with that, Sophia? Does that sound a reasonable figure?
Yeah.
You know, if you'd pushed me, I would have said 67,000 new cases per year. That's a figure I have in my head, but I can't quite remember where I got that from.
Is that wet and dry, or just wet, you're
Oh, I
thinking?
thought that was just wet.
Yeah, well, that might be right. So it was about 45,000 in 2010. So it's entirely possible that it's half as much again by now. That's not impossible, is it? I think. Yeah. So it's a vast population, and that makes, of course, macular degeneration a very significant health issue for people, individuals, but also for the country as a whole, as a public health issue, and it's also therefore a political issue. And so we have a lot of campaigning to do to make sure that ophthalmology in general and macular degeneration in particular is higher up the priority list for our health policymakers and political leaders. So thank you all very much indeed. Martin and Sophia, anything you want to add before we close? I'm afraid we are out of time. Thank you very much indeed for joining us. It's been a very interesting talk, and thank you to all of you for joining us this evening as well. You can continue to comment by email, virtual, I think it's virtual clinics at macularsociety.org. I'm not sure, but we'll put something on the website so that you can go to that and comment on what you think ought to be included in this survey, and then we'll put a survey together and we'll be asking you all to help spread the word, complete it, and help the National Ophthalmology AMD audit get off the ground really well and truly. Thank you very much indeed for joining us all this evening. Next month we're going to be talking about BeoView, the new treatment for wet AMD. That's BeoView at our next virtual clinic on the 20th of April. And I hope to see you all then. Thank you very much indeed, Martin and Sophia, and to all of you. Very good night to you. Good night.